Hey, I'd like to welcome everybody to Pediatric Grand Rounds, and I'm going to turn it over to Dr. Meg McNamara, our residency director, to introduce our speaker for today.
Hi, good afternoon, everyone. It is my pleasure to be here to introduce Dr. Glenn Rosenbluth, my trusted colleague and dear friend for many years. Dr. Rosenbluth is clinical professor of pediatrics who specializes in caring for children with medical complexity. He completed medical school at the Weill Medical College of Cornell University and completed his residency and chief residency here at UCSF. He also has completed a fellowship in hospital medicine through the UCSF Department of Medicine, the UCSF Teaching Scholars Program, and the Intermountain Healthcare Advanced Training Program. And he's currently enrolled in the Academic Pediatric Association's Advancing Pediatric Leaders Program. Clinically, Dr. Rosenbluth works on the pediatric hospital medicine service here, caring for hospitalized children with a wide range of conditions. And he's also the pediatrician for our UCSF Craniofacial Center for both inpatient and ambulatory settings. And previously, he served as the associate director for our UCSF Pediatrics Residency Program. As the Director of Quality and Safety Programs for the UCSF Office of Graduate Medical Education, Dr. Rosenbluth has a particular interest in understanding how to engage residents and fellows in hospital-wide quality and safety initiatives. He oversees REFLECT, which is a resident and fellows systems improvement incentive program, which engages over 850 residents and fellows annually in patient safety programs. Dr. Rosenbluth has been involved in several research projects studying the interface between medical education and patient safety. He had a leadership role in the NIH-funded IPASS study, which demonstrated significant reductions in medical errors and preventable adverse events after implementation of a handoff communication bundle, as well as that of the PCORI-funded patient and family-centered IPASS study. He's also currently a co-investigator on Dr. Naomi Bardak's Family Input for Quality and Safety study, which a mobile technology approach allows patients and families to report safety and quality concerns during their hospitalizations. So one of Dr. Glenn Rosenbluth's passions is, in addition to patient safety, which he's been studying for many years, is about health and healthcare inequities nationally and within UCSF. And I think we're going to hear some of that today in the talk. His talk is on Patient Safety 2.0, Disparities, Interventions, and Opportunities. So welcome, Dr. Rosenbluth.
Thank you very much. I appreciate it. So I'm going to just start with a land acknowledgement slide to acknowledge the Ramayatu Ohlone people, who are the traditional custodians of this land, and pay our respects to them and thank them for their stewardship and support, and look forward to a continued relationship of mutual respect and understanding. So we're going to talk today about Patient Safety 2.0, Disparities, Interventions, and Opportunities. And I'll say up front, I very much welcome discussion and feedback on this topic. This is a relatively new area that we're getting into. And so I'm happy to share some thoughts with everyone today. I have no personal financial relationships to disclose. So this is where we're going to go today, understanding the basic epidemiology of medical errors and preventable adverse events. And I'll use that term preventable adverse events, but the more common or more lay term for that is just harms. I'm going to describe how we get data about patients and safety events, because I think this is fundamental to understanding how we get data about disparities. I'm going to provide some specific examples of disparities in safety events. Then we'll describe the potential benefits of improving communication on rounds in all languages, just as an example of an intervention, and then some additional gaps and opportunities to talk through. So I wanted to start, and people have likely seen some variation on this slide, which is just causes of death in the United States, making the point that medical errors have historically been estimated to be the third leading cause of death in the United States. Certainly, within the past year, COVID has risen. And so COVID is actually now the third leading, bumping medical errors to fourth. But this estimate of several 100,000 deaths per year linked to medical errors is a number that stood up through a variety of sources, both government sources as well as foundations and independent researchers. And while the number probably varies between different studies, whether it's 200,000 or 400,000, the 250,000 is a good aggregate estimate of deaths from medical errors. So before I get too deep, I want to actually help us define what an error is in the medical error context. So I'm going to use this definition that an error is the failure of a planned action to be completed as intended, or the use of a wrong plan to achieve an aim. So for example, if one intended to prescribe antibiotics and forgot to do so or delayed doing so, that would be a failure of a planned action. On the other hand, if a patient should not have received antibiotics and did receive antibiotics, that would be the use of the wrong plan. And that's different from an adverse event, which is harm, and that's an injury caused by medical management. And that's an example of, say, a patient who has an allergic reaction to an antibiotic, but no one could have known in advance, and the antibiotic was the correct antibiotic for that patient's infection. But because it was the correct antibiotic and there was no way to know the patient was going to have an allergic reaction, but the patient still had a reaction, we would call that an adverse event or harm. And then in the middle, in this overlap between errors and adverse events, is these preventable adverse events, which are harms caused by errors. So that would be if a patient had that allergic reaction, but we should have known that the patient was allergic, or the antibiotics weren't needed to begin with, and therefore the harm to the patient was preventable. So we just like to remember that all errors are not created equal. Not all errors result in adverse events, and not all adverse events or harms are caused by errors. So I'm going to try to be clear as I talk about the different categories, what we're talking about in each setting. And I want to give a little bit of a global overview of the types of errors that we see in pediatrics. These are data from the first IPASS study that UCSF was a site in, and this is the lead paper that Amy Starmer published. And this is looking at medical errors across 10,000 admissions in 9 institutions across the United States. And again, BCH was a site. And this estimate of all errors total, about 24.5 errors per 100 patient days, stands up across studies. It's about 8 or 10-fold higher than the preventable adverse events. So most errors in kids don't cause significant harm. They might be an extra dose of antibiotics, or fluids that went on a little bit longer than were necessary, or something like that, that don't necessarily cause harm, but might still count as an error. And certainly the largest category, the largest single category of errors in pediatrics is medication errors. That said, as we drill down to the underlying causes of errors in our patient population, over time, it's been well documented that communication is a key factor, is a root cause of sentinel events, of major harms to patients. So sentinel events are not all sort of one category, but it's these large preventable harms that we should have known about, we should have been able to avoid. And as the Joint Commission has looked at these data over decades, it's pretty consistently shown that communication is a major contributor to medical errors in pediatrics. In medicine overall. And that's why a lot of the work that we've been involved with has been communication related. So when we think about patient safety and reducing medical errors, I'm going to start with what I like to call version 1.0. And a good example of a transition point with, or a seminal work in this field is in 2006 when Peter Pronovost published work on central line bundles in ICUs across Michigan, basically showing that if you standardize central line placement and add in checklists and some important teamwork strategies, catheter-related bloodstream infections can be decreased substantially. And this is very important because catheter-related bloodstream infections, or CLABSIs as we call them, used to be thought of as inevitable. And what Dr. Pronovost showed is actually with structured interventions, they don't have to be inevitable. Atul Gawande popularized a lot of this in the Checklist Manifesto, talking about the benefits of checklists, and certainly Dr. Gawande has written in other settings. Bob Wachter has written a lot about the impact of technology, including provider order entry. Some of you may remember when the electronic health records were rolled out, we thought these allergy pop-ups and recommended doses and such would be the solution to a lot of medical errors. And certainly were the solution to some, but not all, as Bob talks about in his book, how technology led a hospital to give a patient 38 times his dosage of a medication. And many of you know that, in fact, that hospital was UCSF Benioff Children's Hospital, that a patient sustained a severe reaction after having a 38-fold overdose of a medication. And you can read about that. UCSF was very open about allowing Dr. Wachter to publish that. And then my big introduction was my work on the IPASS handoff study, which looked at changes in medical errors after implementation of a handoff program. And what we were proud to show was that errors fell by about 21%, and harms, in particular preventable harms, fell by about 30%. We then took some of the IPASS principles and used them in a co-produced family-centered communication program, basically an adapted family-centered rounds bundle. And Elisa Khan published that a couple of years ago, and I'm going to talk about some of those data today. So it's been a long journey, but I want to highlight the fact that though we've had overall improvement in safety, that doesn't mean that we've had an overall improvement in disparities. And I just want to share a little framework for that. So when we think about improvement work, these graphs are each showing improvement on the y-axis and time on the x-axis. And this first graph shows two populations, one purple, one teal. And as time goes on, both populations show improvement. So no change in disparities, more of the same. The middle box shows an intervention in which the purple group stays the same, but the teal group shows substantial improvement. So overall, the average improvement is higher, but the disparity, more importantly, is eliminated. And then in the worst case scenario, an intervention is put in place that only benefits the group that is already showing greater level of improvement. So the purple group improves. If one took the average, the improvement would still be higher, but the disparity is actually worse. So we want to keep this in mind as we think about how we're improving patient safety, but also how we're getting at disparities. So the road to patient safety is a very long and crowded road and messy, and there's a lot of things to unpack as we go down this road to understanding patient safety overall. But then the road to understanding disparities in medical errors and patient safety is a very windy road. Now, I like this picture because it's very windy. I don't think the disparities in medical errors are in any way as manicured and clean as Lombard Street. But I did want to make the point that it's very windy, and it is almost as if there is a do not enter sign, because there's so little out there about disparities in medical errors. And so I think it's an area that's ripe for a lot of work and more understanding, and I'm very proud to be affiliated with some people who are doing that work. I want to acknowledge that we've been talking about this for a long time. And in fact, the National Academies Press put out this report called Unequal Treatment 20 years ago, in which they highlighted that disparities in care lead to disparities in outcomes. There's disparities in the care we intend to deliver, but also the care we don't intend to deliver. So again, those errors and harms. And here we are 20 years later with still not significant improvement in disparities. And just as a highlight to that, just this past weekend, Dr. Kayla Carvonen from neonatology here at UCSF was talking about the impact of structural racism on adverse postnatal outcomes for Black preterm infants. So really still a lot to unpack there, and some people at UCSF doing fantastic work in this space. So at this point, I just want to pause for a moment. I want to acknowledge and disclose that I am not an expert in healthcare disparities. And I welcome feedback and discussion on what I'm putting out. I have tried whenever possible as I share studies to identify the sources of race and ethnicity data. And I'm going to talk about some of the challenges in that data, as well as the challenges of the use of the term race. And when I talk about studies, I will generally be using the groupings used by the authors of the work I discuss. So in order just for consistency and fidelity to the research, that's why I'll be using the term race, which is a variable, and I'll talk about the problems with that. But also, I'll try to identify the sources whenever possible of where those data come from. I also want to remind us that JAMA put out updated guidance on the reporting of race and ethnicity in medical science journals within the last year. And they remind us, the editors remind us, that race and ethnicity are social constructs without scientific or biological meaning. And the reporting of race and ethnicity should not be considered in isolation, but should be accompanied by reporting of other socio-demographic factors and social determinants, including concerns about racism, disparities, inequities, and the intersectionality of race and ethnicity with these other factors. I'm going to acknowledge up front that not all the authors I cite have done this. This is a relatively new awareness, but I think there's still things we can learn from some of the older literature. I also want to highlight this piece by Dr. Rhea Boyd called On Racism, a New Standard for Publishing on Racial Health Inequities. I think it's interesting that for the past couple of decades, anytime anyone gave a talk on patient safety, they cited the IOM report from 1999. Now at PAS this past weekend, multiple people talking about health equities in research were highlighting Dr. Boyd's work as reframing the issues about how we think about race versus racism as a contributor to health inequities. And when Dr. Shaquita Bell talked about this weekend, she encouraged us to stop using the word race and start using the word racism. Again, because of its use as a variable in some of the studies, I'm going to acknowledge that to reflect the way the research was done, I'm going to use the term race, but I hope people understand the intent behind that and the goal of highlighting the need for change. So as we get into this, as we start talking about medical errors and adverse events, it's important to ask the question, where do we get data about medical errors and adverse events? And these are just some of the places where we get errors or get data about errors and adverse events. And I'm going to go through them in some detail with examples of each. But before I get into that, I'm going to ask the question of where do we get race and ethnicity data and how good are those data? So we get these data from a couple of sources, EHR demographics, so EPIC reports, for example. There's large administrative databases, for example, Medicare databases or Press-Ganey databases. And then again, surveys like hospital-based surveys where HCAP surveys, which are administered by Press-Ganey, or research-based surveys. And I'm going to talk about both of these categories. So how good are those data, the race and ethnicity data? This was an interesting study out of Columbia University in 2019, looking at challenges with the quality of race and ethnicity data in our observational databases. And what this research group found was that in the EHR, race or ethnicity was unknown for 57% of the people. What the group did then was cross-reference EHR data with patient experience data from CGCAPs and HCAP surveys administered by Press-Ganey. And the thing about those surveys is that the surveys are linked to patients, and patients can self-identify their race and ethnicity on those forms. And what they found is that when patients directly recorded their race and ethnicity, 86% provided clinically meaningful information, and 66% of patients reported information that was discrepant with the EHR. So real challenges there. And I'm not going to say that all the data are garbage, but we're not at the point of gold yet. And I want to talk about what UCSF is doing in this space. So this is a form that most of you haven't seen, largely because paper forms went away at the start of COVID. But the Health Equity Task Force developed this form to allow patients to report their identities in a lot of different ways. With about 30 different options of which people can choose as many as they want for self-descriptors. And the goal of allowing this increased granularity of data is to eliminate the large population of patients who previously were classified as other without the granular data. And by using a more granular, what's called the UCSF-derived race and ethnicity field in APEX, one of the things they've seen is that this population of people classified as other went down from 17.6% to just 6.6. I want to go back to this, and it's not to acknowledge that groupings, or not to say that groupings were always right. And certainly there are benefits to the granularity data, but also the creation of this UCSF-derived race and ethnicity fields allows for some socially meaningful groupings. So for example, while someone from Thailand and someone from Japan might have very different ancestry, some of their experiences in the hospital, the way they are treated by staff, discrimination that may be faced by different groups may have some common themes between someone from Thailand and someone from Japan, even though their ancestry is quite different. And so what these data allow is for people to ask those questions and try to unpack those differences. So having said that, now I'm going to really go deeper into where we get data about medical errors and adverse events. So I've put up these different ideas. So chart reviews, actually going through charts, and chart reviews can be with trigger tools or with expert opinion or combined, and I'll talk about both of those. Incident reports, I'll ask how many people here have completed an incident report, probably not as many as we'd like. I myself am guilty. There's active surveillance. So actually going through every time there's a positive blood culture, people go looking and see if it was a central line associated bloodstream infection. Surveys, both as internal surveys, culture of safety surveys, as well as for research studies. And then some new tools that are coming online. So starting at the top with just a little bit about trigger tools. So I'm going to share the example of the GAPS trigger tool, which is the global assessment of pediatric patient safety that was developed by Chris Landrigan in Boston. And this involves basically a list of 30 some odd different triggers. And some of them are manual triggers that a chart reviewer going through a chart might look for something like an abrupt medication stop. Some of them are automatic triggers, like every time someone is prescribed oral vancomycin, because oral vancomycin is really just used for C. diff infection. And then there are some triggers that could come either manually or automatically, such as serum creatinine doubling. And triggers, and these triggers just trigger a review. They don't mean they automatically count as a harm or error, but then they undergo review by experts in the field who determine whether or not an error actually occurred and whether harm occurred to the patient. So when David Stockwell looked at racial, ethnic, and socioeconomic disparities in patient safety events for hospitalized children, he used the GAPS tool together with Chris Landrigan. And what they found using a trigger tool was that Latinx children experienced more preventable adverse events. So those are the harms at almost double the rate of white or Caucasian identified children. Black children experienced a slightly lower rate, but it was not statistically different. So that's one example of the kinds of disparities that can be unpacked. In this study, they also found that publicly insured children were experienced more preventable adverse events. And certainly I want to acknowledge there's a lot of intersectionality between these different demographics. And I'm not speaking to their methodology. Certainly they did multivariate analysis and found out that these were their results based on that approach to their analysis. When looking at incident reporting, I'm going to share some data from our internal incident reporting system that I think has been really interesting for people to look at. This is some work led by Matt Pantel together with Arby Bekmisian and Kayla Carvonen and Paige Porter and Jim Stotts from the patient safety team and John Newhouse that has been submitted. Looking at incident reporting, finding that Black and African American identified patients at UCSF had increased rate of patient safety events, not significant when the harm events. Similarly, Latinx patients had higher rates as well, and children with public insurance. So some of the same themes coming out over time. Interestingly, in this incident reporting, which is again all voluntary reporting, a preferred language other than English seemed to have an impact, but then became insignificant in the fully adjusted model. So the bolded items here were all statistically significant and remained in the fully adjusted model. Now, to go from, we talked about trigger tools and we talked about incident reports. Lucy Schulson in Boston has tried to compare these two to figure out where we get some of the differences and what we can unpack. So she looked at two reporting methods, both voluntary reporting, which is incident reports, and then automated reporting using the IHI trigger tools, not the GAPS tool, a different trigger tool, but same basic concept. And she showed that if you just look at incident reporting, there actually don't look to be significant disparities. Again, this is different from the UCSF data, which did show disparities just based on incident reporting. But when combined, looking at voluntary reporting on the top versus automated reporting with a trigger tool, you see that voluntary reporting probably undercaptures, well, does undercapture some disparities. And in particular, the incident rate ratio for events in our Black identified patients were significantly higher when looking at automated reporting. So I want to acknowledge that this data using the IHI trigger tool is different from the GAPS data, which didn't find a difference. And the Boston Children's report of incident reporting, voluntary reporting, was different from the UCSF report. And so I think this just gets at, there's a lot to understand there. And in particular with incident reports, I think it's hard to know the interplay between patient demographics, structural racism, and other issues that may impact reporting. So for example, I'm just throwing out a hypothesis that in a region that has a high level of racism, that it is possible that when patient safety events occur in minoritized patients or occur to minoritized patients, they're underreported. Whereas in a population with great attention to racism, it is possible that there would be even greater sensitivity and increased reporting. I think those are both plausible, and we need a lot more data to understand and some good qualitative work to try to understand how that's playing out. So I talked about trigger tools and incident reporting, voluntary reporting. I want to talk a little bit about family-based reports. So in the patient and family-centered IPASS study that we were involved in, led by Elisa Khan, we actually conducted parent and caregiver safety interviews, both weekly and at discharge. And we asked about whether the patients experienced adverse events or harms, errors of omission, commission, and non-harmful errors, and any other issues that they thought were important patient safety issues. We then aggregated this family reporting with our trigger tools, including expert opinion on chart reviews, as well as incident reports from the site, as well as staff surveys, to get a sense of where our error reports are coming from. And really interesting, what Dr. Khan showed is that in this study that had over 7,000 admissions, we had 179 sources of validated medical errors. And of those 179, 137 were found in medical record review and 39 were reported by families. But interestingly, there was a subset, 22% of our medical errors were only reported by the family. So if we hadn't actually asked the patients and the families, we wouldn't know that these errors occurred because they weren't found in the medical record chart review or in the IR system. Similarly, that was non-harmful errors. For harms, actually a higher proportion were reported only by the family. And I want to make the point on both of these that all of these were validated by two investigators going back, reviewing the incident, and making a determination of whether it was in fact a harm, whether there was in fact an error involved. So it wasn't just simply the family filed a report or answered a survey question in a particular way, but it was actually validated by investigators who, two separate investigators, blinded, who agreed. In this study, we also found that comfort with English impacted the odds of preventable adverse events. And so when we did a deeper dive looking at various predictors of preventable adverse events, limited comfort with English versus comfortable with English, there was an increased odds of experiencing a preventable adverse event. Other variables did not sort out in this multivariate analysis, again, trying to account for as many confounders as we could. Those who notice the bottom, some college versus more or no college, those with some college experiencing higher rates of preventable adverse events, we think that's probably a surveillance issue. We think people with college education may be more tuned in to identifying harms in their children and bringing them to the attention of the healthcare team. But again, a lot to unpack there. And then finally, the FIX study, which I'm pleased to be involved with, that Naomi Bartek is the PI on, that is a UCSF and ZSFG-based study, giving families a mobile responsive tool. It looks like an app, but it's a mobile responsive website through which they can report safety concerns in any of these areas: medication, equipment, communication, unexpected events, and other, as well as things that went well. That was a request of the Family Advisory Committee, and they can give us some specifics about what happened. And from the pilot data that was recently published, we showed that patients and families reported about 8.2 safety events per 100 patient days. So that's just what they're reporting to us, not what they experienced, but maybe didn't know about or didn't report. And in these data from the pilot, Latinx identified families were less likely to report errors at 3.9 versus 8.2 reports per 100 patient days. In the multivariate analysis, that gap disappeared, but a Medicaid gap did persist. So again, one of the most persistent gaps is the Medicaid or payer mix gap, which obviously has intersectionality with a lot of other factors. We're now on to FIX2, which is taking that pilot data and going a little further as a multi-site study, so BCH and ZSFG, and it is bilingual and bicultural. And so the app has been translated into Spanish, and our Spanish-speaking patients have that opportunity. And we've been guided by Drs. Elena Fuentes-Affleck and Alma Martinez, helping ensure that we're addressing cultural sensitivity appropriately. And also Dr. Anjana Sharma, who is also a lead on the study and taking some of this work into the outpatient setting. So hopefully we're going to have some really interesting stuff to share. From the early usability testing of the app, what was found by our research team, Melissa Camana Sosa and Maite Garcia, who did the usability testing. Interesting, we asked patients and families how they would use the app, and in particular, would you report positive and negative experiences? And what we found was that a subpopulation of people said that they were comfortable reporting positive, but that they would not report negative safety experiences in the hospital. Importantly, only Hispanic and Latinx identified Spanish-speaking patients felt uncomfortable reporting negative experiences. And these data were presented by Maite Garcia at the UCSF 14th Annual Health Disparities Research Symposium. So I think what we need to figure out is how can we safely capture these experiences, knowing that patients may not be comfortable reporting. What are their reasons for not feeling comfortable telling us about those safety events? And how can we create an environment so that we can safely capture these experiences? So this is about whether or not patients actually feel comfortable telling us. So that's a big opportunity for us, is how can we create an environment in which all patients feel safe sharing their negative experiences? And similarly, and perhaps more importantly, how can we create an environment in which all patients are heard? So changing the environment from our end. And I want to acknowledge that this is our responsibility. The burden cannot be on our patients to speak up. It has to be on our providers on our healthcare system to create this environment. Thinking about this environment in which all patients are heard, there was a really deeply moving piece this month in Elle magazine, which is not a magazine I usually read, but Serena Williams writes about how she literally saved her own life. And this is in the context, as noted here, about the health disparity that Black women are nearly 3 times more likely to die after childbirth than white women. And Serena Williams writes about her experience. She writes, and I'm quoting her, "In 2010, I learned I had blood clots in my lungs. It wasn't a one-off. I'm at high risk for blood clots. After my daughter was born in 2017, I asked a nurse, when do I start my heparin drip? Shouldn't I be on that now? The response was, well, we don't really know if that's what you need to be on right now. No one was really listening to what I was saying. She then went back to the OR because she was coughing so much that she tore her stitches. I spoke to the nurse. I told her, I need to have a CAT scan of my lungs bilaterally, and then I need to be on my heparin drip. She, the nurse, said, I think all this medicine is making you talk crazy. Later on, not surprisingly, the CT was done and it was positive for multiple pulmonary emboli. And thank goodness she survived. But I think this is a really compelling example of the ways in which we as a healthcare system haven't listened and still don't do a good job of listening to our patients, and in particular, our minoritized patients. So I want to address some issues, talk about some issues in racism and stereotype threat as they relate to this space, acknowledging that racism may influence what providers report about patients. As I said, who files an incident report and who doesn't. Racism may influence what information providers accept from patients. So whether we actually listen and hear patients when they provide information about their health needs. And trust. Certainly racism may influence trust. And there was a really important study published a couple of years ago using California data over the last 2 decades about lack of trust in the healthcare system. And in particular, that while trust in the healthcare system has increased among Latinx identified individuals, Black identified individuals have not shown any change in the trust. And I would say that that's because healthcare systems have not yet earned that trust. Also, under the umbrella of stereotype threat. So for those who aren't familiar with the term stereotype threat, that's when members of a minoritized group acknowledge that a negative stereotype exists in reference to their group and may change their behaviors to avoid confirming negative stereotypes. So that may influence what information patients share with their providers about demographics, about medical history. Stereotype threat may also impact how patients advocate for their children, whether they are comfortable speaking up in the hospital, as well as the emotional strain imparted by stereotype threat may influence how patients take in information while they're in the healthcare system. So a lot for us to understand here and to unpack so that we can better serve our patients. I want to talk about some other preventable harms. We've thankfully started to expand our definition of harms in the hospital, and through some important work related to security calls, some important work done by the team that developed the Code Care program, we're really starting to talk very differently about the harms that patients experience in the hospital. So an example is unnecessary security involvement. So this paper was published late last year. This is out of Yale Department of Pediatrics, looking at racial and ethnic disparities in physical restraint use for pediatric patients in the emergency department. And what the group at Yale noted was that Black non-Hispanic identified patients had a significantly increased adjusted odds ratio of experiencing physical restraints in the pediatric emergency department. Again, this is not the adult emergency department, not that that matters, but just to know that this is our population, this is us, this is our people. And certainly we need to change that. Disparities in hospital violence exist within UCSF and ZSFG. Camila Cribb-Fabersoon, Karina Jacopetti, and Hannah Corman gave a fantastic grand rounds last year where they talked about racial disparities in hospital violence, sharing University of Michigan data, but also sharing ZSFG data, in which they shared data from SFDPH that Black patients made up 24% of emergency department visits, but 70% of use of force incidents. And I thank these three physicians for allowing me to show this slide of their work that they did. Certainly within UCSF, there's a lot of attention to unnecessary security involvement. I know April Edwell and I believe Jess Wong are looking at this in the PICU, and Kayla Carvonen and Liz Rogers are looking at it in the intensive care nursery, and Matt Pentel's involved as well. So more to come on that. Unnecessary attendance sitters. So understanding that the impact of having a bedside attendant is different for different patients. And within the last 2 years, UCSF has transitioned to having social work 24/7, which has enabled us to clear a lot more patients so that patients don't have unnecessary attendance at their bedside when they're really not necessary. Untreated or poorly controlled pain. I put this up there because we talk about it as a general disparity in care, but using the methodology we've used for our patient safety studies, uncontrolled pain is a harm, and therefore it is a preventable adverse event. It is an error that causes harm. And there's a lot more data on this as you unpack. And again, this is not meant to be a broader talk on healthcare disparities. My work is focused more on patient safety and adverse events, but certainly as we think about adverse events, any area in which patients don't receive the right care because of their identities would fit in this category. So a few takeaways so far before I transition a little bit. We know that disparities exist in patient safety, and we have to look for them in multiple ways and expand our definitions. And we know that our data aren't good enough yet. So for the last part of the section, I want to talk about one potential area and potential benefit of improving communication using the example of rounds, and in particular, rounds in all languages. So I mentioned that we were involved in the patient and family-centered IPASS study that took some principles from IPASS and adapted them to patient and family-centered rounds. BCH San Francisco was a site for this study, and thanks to Brian Jin, who was part of our research data collection team on this study. I want to acknowledge that family-centered rounds is a bit of a touch point for a lot of people. And there was this interesting piece about family-centered rounds, a pediatric residence challenge that was written 2 years ago. That said, there was also this piece from last year, We're All Learning Together, an imperative for patient and family-centered rounds from the patient and family perspective. So lots of different perspectives on family-centered rounds. I'm going to share a little bit the patient safety perspective. So in this study, we wanted to determine whether improving communication between families, nurses, and physicians would be associated with reduced rates of medical errors and adverse events and improve patient and family experience without having any changes to the rounding processes. As I mentioned earlier, we used a lot of different sources for medical errors and adverse events, multiple methods of error surveillance, including family safety reporting that was incorporated into surveillance. This is just a graphic showing how IPASS aligns with rounds. The idea that illness severity and introductions, everyone introduces themselves and the patient and family shares first. And then for the patient summary portion on family-centered rounds, the nurse shares second, and then the physician speaks. And we go through the summary and the to-dos. And then this synthesis by receiver from IPASS is adapted into eliciting a teach-back from the patient and family, in which the patient and or family summarizes the plan, or if that doesn't feel appropriate to the situation, they ask the nurse for input and ensure that we've gotten a teach back and a good understanding of the plan. And so, again, this study was across 3,000 admissions at 7 sites, and BCHSF was a site. And what we found in this study was that harmful medical errors, those preventable adverse events, fell by 38% with implementation of this structured family-centered rounds bundle. So really impactful changes in patient safety and real improvements in family reported experience of what was said on rounds, understanding of written updates, shared understanding, and then the nurse's involvement with the patient and family, statistically significant improvement in all of these family-reported measures with the implementation of this structured family-centered rounding, with no changes in the duration of rounds or teaching on rounds. So then the natural question about family-centered rounds, and this comes up, is do patients with limited comfort with English benefit from IPASS-FCR? And so in this study, we used self-reported preferred language using the AHRQ guide, in which we asked patients, what language do you feel most comfortable speaking to your doctor or nurse in? And if they chose something other than English, they were categorized as limited comfort with English because that was not their most comfortable language for speaking to their doctor. And to answer the question, do patients with limited comfort with English benefit from IPASS family-centered rounding? In the unadjusted analysis, there actually appeared to be a very substantial gap, much greater improvement for reduction in preventable adverse events in children with limited comfort with English parents compared to those who are comfort with English. In the fully adjusted analysis, the difference wasn't as significant, or it was not significant, but there was still improvement. So families with limited comfort with English improved to the same degree as those who are comfortable with English, making the point that we shouldn't avoid family-centered rounds just because a patient or parents don't speak English. And in fact, this study out of Children's LA just in February, 2 months ago, showed variation in family involvement in rounds between English and Spanish-speaking families, making the point that for some metrics, like whether the family was present, whether we introduced ourselves, there wasn't much difference. But whether the family got to ask questions at the start, Spanish-speaking parents did not always have the opportunity to ask questions at the start. Discharge criteria discussed with family at a lower rate with our Spanish-speaking, I should say their Spanish-speaking patients. And I think this one is important, this issue of whether the family was involved in the initial discussion versus updated after the team discussed. Really significant, fewer percentage of Spanish-speaking families that were involved in the initial discussion, greater proportion that were just updated after the team discussion. So just thinking about the model, if we want to include patients and families in rounds and use that as a strategy to reduce patient safety, we have to start with whether patients and families actually want to attend rounds. And they're not going to want to attend rounds unless they're included in rounds. And so we want to include all patients the same way in rounds. Now, one of the big things I've always told our team, if a patient and family decides not to participate in rounds, if they don't want to participate, then we are being family-centered if we do rounds in whatever they want. That said, we have to own as providers what are the reasons why some patients and families might not want to participate in rounds, and what are we doing that makes them feel like that rounds aren't their place. So we have to improve psychological safety, and then once we improve psychological safety, we can improve patient safety. I want to acknowledge there is a broader context, and probably the greatest data, the largest body of disparity data, is that language discordance does increase the risk of medical errors. And I've touched on this a little bit already. I want to mention it in the context of interpreters. We know that non-certified interpreters, so using a provider who's not certified or a family member, is a higher risk. Glenn Flores has done a tremendous amount of work in this space. His estimate were that about 31 translation errors per encounter occur when you use non-certified interpreters, the most common being omission and false fluency. Elaine Kuhn at UCSF over at San Francisco General looked at this and asked the question, what about if we use Google Translate for our discharge instructions? And what she found, looking at free texted ED discharge instructions, was that they were only 92% accurate into Spanish and only 81% accurate into Chinese. And in fact, some inaccuracies were very significant in discharge instructions. And I'm just going to show one example of that with this set in the middle. What she did was take English language original sentences, translate them into Spanish and Chinese, and then back translate them back into English. So in this example, hold the kidney medicine until you have a chance to speak with your kidney doctor. When it went to Spanish and then back to English, it was back translated as keep the medication for the kidney until you have a chance to talk with your kidney doctor. And to Chinese, it actually specifically said, keep taking kidney medicine until you talk to your kidney doctor. So the complete opposite and a potentially life-threatening error that occurred in this example of a Google Translate fail. So we definitely don't want to be using or relying on tools like Google Translate for important work. And just to make sure that everyone knows, on the CareLinks landing page that opens in all of our health system computers at Benioff Children's, there is, you can search on the page for Translate and get materials translated. It helps to do it a day in advance. And on C5 MedSurg, Gavi can help us with that. But really important to make sure that you're getting things translated accurately. And to remind you, the UCSF policy for use of interpreters, and what I put out is my golden rule of interpreters, is that if you don't speak the language well enough to get your own care in that language, so for example, if you speak Spanish, if you were in Mexico and got appendicitis, if you'd be comfortable getting all of your care in Spanish with no interpreter, then take the test, get certified, and provide care. But if you would want an interpreter back to English, then certainly your patients deserve the same. So as I wind down, before we wrap up, I want to acknowledge that I've talked a lot about errors and adverse events and harm. I want to acknowledge that none of us are perfect. We will all make medical errors. I have my list of medical errors that I've made. I hope that I will make fewer in the future, but none of us are perfect. Involvement in a medical error and/or adverse event can have a significant impact on our career. And Susan Scott has written about the trajectory of the second victim, in which people have their careers deeply impacted by the moral distress of making a medical error. And certainly there have been some cases in the news recently. And just to remind you to ask for help if you're involved in a medical error. Take care of yourself, take care of your colleagues. UCSF has a Caring for the Caregiver program. I'm sorry I didn't put up a link, but if you Google UCSF Caring for the Caregiver, they can connect you with the right resources, peer supporters who can help you understand how to navigate this very challenging world. Some opportunities to get better. We need to improve the quality of our data. We need to consider both the source and the context, whether these are data that are just input by someone who may not have the clinical context, whether they're data that are directly reported by patients and families or by on-the-ground physicians. And we need to create better data. We may need new systems of databases. We may need new ways of collecting our data. We need to study and dismantle health disparities. As we design research interventions, we need to consider the differential impacts and refine or redesign our interventions and make these the primary aim of the study, not the secondary aim. That's something that the IPASS study group has determined going forward, is to ensure that all of our work is not just focused on acknowledging disparities, but actually having the aim to study and reduce disparities, and not just in the outcome, but in the study team, making sure we have diverse members of our study team and that we're involving diverse institutions. So not just university institutions, but community-based institutions, not just institutions that serve relatively high-income patients, but also institutions that serve relatively low-income patients, not just primarily white populations, but Black identified populations, Latinx identified, all other identified populations, to make sure that we're unpacking this and acknowledge racism and be anti-racist in the work that we do. Co-produce our work with diverse patients, families, and institutions, as I mentioned, and act as if your family member were the patient. I want to close with this quote that Dr. Rhea Boyd gave during her grand rounds 2 years ago to us. Never say to me ever again that we're only going to focus on low-hanging fruit, as if we can't systematically change the way our systems work overnight, because we absolutely can. And I thank Dr. Boyd for keeping this front and center. I just want to close with some gratitude to some collaborators and mentors. Certainly the IPASS study team and Dr. Elisa Khan led a lot of our recent work, especially looking at disparities, and the IPASS Coordinating Council with Drs. Landrigan, Spector, Dan West, who many of you know, and others. The FIX team led by Naomi Bartik, who's the PI, Jyothi Marvin, who's been one of my most important teachers in this space, James McGuire, who generously gave me some early feedback on this talk, which I hope I incorporated. Some of my important career mentors, Drs. Lee Atkinson, Steve Wilson, and Andy Auerbach, who helped me get my research footing in this space. UCSF research or residents, fellows, and faculty, all of whom I've learned from, and a couple of funding sources for some of the work that we've done. And I'm going to leave it on this slide. And I'm sorry I've only left 4 minutes, but I'm happy to take some questions.
Thank you so much, Glenn, for that fantastic talk. It was really informative and pretty unsettling in a lot of ways, but perhaps not very surprising in others. So appreciate the information sharing. I'd like to open it up for questions here. I don't see any questions in the chat or in the Q&A section yet. So I will ask just a pragmatic question. One of the things that you shared was that we in the BCH have a new form that's open for the patients and their families when they're admitted that you described. You showed it. We ask because we care. Can you tell me, is this form that they're asked to complete available in multiple languages?
It is. So the challenge is that the form is barely available anymore because it was created by the Health Equity Council right before COVID. And then we did away with paper forms very quickly. And so while all of those choices still exist by the registration staff, the patients don't necessarily see all these choices in a patient-facing way. And so I've escalated that to the Health Equity Task Force and Dr. Malcolm John, who's the medical director of health equity for UCSF Health. And they're aware and trying to rethink how this comes into play. But it's challenging. And in fact, those of you who use MyChart, if you're a UCSF patient, will know that all of those choices don't exist within MyChart. And so as part of this, we escalated that to Dr. Russ Kachina, who's the Chief Health Informatics Officer, to fix that. So again, it comes down to we need better data. We just don't know where our gaps are yet. And some of this really has to come from our systems, and some of it has to come from just talking to patients.
Mm-hmm. Right. Sandrain, you had a question?
Yeah, Glenn, thanks for this fantastic talk. I missed the beginning of it. I had the privilege of touring the Lieutenant Governor through the Canbar Center, and hopefully I had convinced her that she should give lots of resources to patient safety and education. I wanted to just briefly ask, I know you didn't go into detail about patient-centered rounds, but I often have been wondering, are we trying to do way too much during rounds by being both patient-centered and trying to teach and trying to get our work done for the day? Do you have any thoughts on that?
Yeah, I would say absolutely we're trying to do way too much, but we can sort of reinvent the system. I think we've decided that rounds are this thing that happens at the beginning of the day. There are some interesting models that are happening. University of Maine Medical, or it's called Maine Medical Center, was doing a pilot in their ICU where they actually spend more like 45 minutes at the bedside of each patient in this pilot ICU, and they do all the work, and they acknowledge that the entire day is spent going patient to patient, integrating teaching and the work. But I think as we have tried to do this all and do it in a 2 to 3 hour window, it's impossible. And we do have to find the balance between patient-centered rounds, learner-centered rounds, efficiency rounds, the interprofessional team. And I completely agree with you, we can't do it all at once. I think we have to figure out as an institution how we bring these together. And I think this gets at that question that Ria asked. It's not low-hanging fruit. It's not just creating a teaching appointment or saying rounds have to end by 11. We have to rethink, how do we make good, effective, efficient teaching opportunities on rounds while still providing high-quality, equitable patient care?
Thank you. And there's one question from Dr. Jim Padbury. I see that we're right at the top of the hour here. So I'll say that his question is, some of the larger data sets might be explored by latent profile analysis or structural equation modeling, such as mediation analysis, and he's wondering about thoughts on that.
Those are methodologies that are over my head, but if you want to talk about it, please send me an email, because I think there is tremendous amount of work to be done in this space. There's very little work done in the space of medical errors and patient harms related to health disparities, so would love to talk more about it.
Wonderful. Thanks again, Glenn. Excellent presentation. And Rafi, to you to wrap it up.
Thank you, Meg, and thank you, Glenn. That was fabulous, very thought-provoking, a lot to consider. And I want to thank everybody for participating today and look forward to our next grand rounds. Have a good rest of your week.
Thanks.